Hello everyone, and welcome to this special Devex webinar, Improving Prenatal Nutrition, Making the Case for Multiple Micronutrient Supplements. My name's Richard Jones, Editorial Director at Devex, and I'll be your moderator today. Now, this webinar is part of Devex's Focus on Improving Nutrition, a focus area produced in partnership with DSM, a global purpose-led, science-based company active in nutrition, health, and sustainable living. I'd encourage you all to stay up to date on this partnership and the content produced by our news team by visiting devex.com or searching for Focus on Improving Nutrition Devex using your favorite search engine. Now, we're really finding ourselves in uncharted waters with the current COVID-19 pandemic, and beyond the immediate health response, I suspect we'll be seeing the negative impacts on areas such as nutrition and food security for years to come. As many of our listeners will know, women are particularly vulnerable to malnutrition. That includes anemia, wasting, or micronutrient deficiencies before, during, and after pregnancy. During today's webinar, we'll be focusing on ways to combat the inadequate intake of micronutrients such as iron, vitamin A, iodine, and zinc. We'll hear a number of different perspectives on the role of multiple micronutrient supplementation, known as MMS, and its role in improving maternal nutrition and reducing infant and child mortality. We'll also learn how it can boost gender equality by maximizing women's access to the health and nutrition services required for improved nutrition. You'll hear insights on existing and future interventions, an emphasis on the need for cross-sector collaboration to overcome current challenges, and we'll also take some time to discuss how to increase the demand, supply, and delivery of MMS. Now, before we get started, a few housekeeping issues. First, if you have any problems hearing or viewing the presentations, please send a message using the Q&A chat box on the right-hand side of your screen, and one of my colleagues on tech support will assist you as soon as possible. Likewise, if you'd like to pose a question to our panelists, please feel free to submit one using that same Q&A chat box on the right-hand side of your screen, and we'll get to as many questions as time allows during the audience Q&A. Finally, there will be a recording of the webinar, and the slide decks, the presentations, will be sent to all registered attendees after the event. You can also join the conversation online on social media using the handle @Devex and the hashtag #ImprovingNutrition. We'd love to hear from you, so please don't hesitate to get in touch. Now, before I introduce today's panelists, I'd first like to hand over to Dr. Saskia Oosendap, Executive Director at the Micronutrient Forum, to give her opening remarks. Saskia, a warm welcome to you, and over to you.
Thank you, Richard. And good afternoon, or good morning, or good evening, everyone. My name is Saskia Oosendap, and I'm the Executive Director of the Micronutrient Forum, which is a global expert organization and knowledge broker in the area of micronutrient nutrition. So why are we so interested in the topic of multiple micronutrient supplements? Well, because there is no equality in the access to antenatal care that women have, and in the ability of women to consume diets that are sufficiently rich in the essential vitamins and minerals or micronutrients that they need for healthy pregnancies. And as a result, multiple micronutrient deficiencies are prevalent among pregnant women, particularly among those in low and middle-income countries. Micronutrient deficiencies in pregnant women contributes to the high prevalence of adverse pregnancy outcomes, including low birth weight, small for gestational age, and preterm deliveries, and to maternal and child undernutrition. So what are multiple micronutrient supplements, or MMS? Well, MMS are tablets containing 15 essential micronutrients that women need during pregnancies. And recent evidence has shown that MMS is an efficacious way to improve pregnancy outcomes. It is safe, it is cost-effective, and it is affordable, as it can be produced at the same costs as iron folic acid supplements. And as such, MMS can be an important and critical intervention to improve maternal nutrition as part of a package of antenatal care services, and it is ready for introduction and scaling up by national and local authorities with support from the global development and nutrition community. There is therefore a growing interest in the Healthy Mothers, Healthy Babies Accelerator, which was launched last year, September, during the Goalkeepers event in New York. This collaboration, which was coordinated by the Micronutrient Forum, has catalyzed interest and initial investments in this important intervention by bringing together 10 partners listed on this slide. And some of these partners will present during today's webinar from the private sector, the UN, the civil society, and academia. And they have invested together at least $50 million in financial and in-kind contributions to accelerate the introduction and implementation of MMS. The partners have made commitments to accelerate activities in the areas of supply, because inadequate supply can be a rate-limiting step to the introduction and scaling of MMS if it is not addressed early on in the process. To demand, because a strong enabling environment is critical for the introduction and scaling of MMS at the country level, and to delivery, because the successful introduction and scaling of MMS depends upon the success of antenatal care services. Now, as was mentioned before, in the past few months, the COVID-19 pandemic has changed our world. And this pandemic is likely to further increase the need for interventions such as MMS, because its mitigation measures, including the lockdowns, will disrupt food systems and will decrease the availability, particularly of nutritious foods that are rich in micronutrients. And this will make it even more difficult for women to consume sufficient micronutrients from their diets. And for this reason, UNICEF, in their recently released programmatic guidance on maternal nutrition during the COVID-19 response, recommends the introduction of MMS to ensure adequate micronutrient intakes in populations with a high prevalence of nutritional deficiencies or where food distribution is disrupted. So the topic of this seminar is very timely and relevant, and I look forward to the presentations of the panel and to the discussion. Thank you very much. Over to you, Richard.
Many thanks, Saskia. Thanks for framing the issue there and outlining the growing global interest and commitments for MMS. I'd now like to introduce today's panelists, all of whom are extremely well positioned to speak on the issue of MMS and to move the conversation forward. First, we have Dr. Jennifer Bush-Hallen, Senior Technical Advisor for Maternal and Neonatal Health and Nutrition at Nutrition International. And Jennifer will run us through the state of play as well as briefly making the case for why we need MMS and why we need it now. We'll then turn to Indraini Fitriya-Sia, Chief Project Officer at the Summit Institute of Development in Indonesia, who will give us her insights from the field in that country. Finally, we'll hear from Dr. Kristen M. Hurley, Senior Vice President for Nutrition at Vitamin Angels, on delivering MMS to women who need them most. We'll then move into a short conversation, including audience Q&A, so please do keep those questions coming in and we'll get to as many as time allows. First, we'll turn to Dr. Jennifer Bush-Hallen. Jenny, welcome, and the floor is yours.
Thank you, Richard and Saskia, for the introductions and the overview. Maternal nutrition, why we need multiple micronutrient supplements, also known as MMS. As Saskia has mentioned, we know adequate intake of essential vitamins and minerals is critical for a healthy pregnancy. Inadequate nutrition intake frequently leads to poor maternal health and adverse birth outcomes, as mentioned by Saskia. This presentation will focus on MMS during pregnancy in low and middle income countries. In the next 10 minutes, I will go over the importance of maternal nutrition, touch on the MMS evidence, look at key program components for scaling up, micronutrient supplementation during COVID-19, and end with a brief summary. Nutrition International. Who are we and what do we do? For 25 years, NI has delivered high-impact, low-cost nutrition interventions in low and middle-income countries. Over the past decade, NI has worked in partnerships with governments across Africa and Asia to strengthen iron and folic acid supplementation programming and maternal nutrition services. Through this work, we have tried to learn what it takes to scale up ANC supplementation programs and overcome barriers affecting coverage and adherence. NI's role in working with governments, generating and translating evidence, and advancing women's empowerment has formed much of the work that I'm going to speak about today. Firstly, starting with maternal nutrition and looking at the key to accelerating progress. As we know, the health of women and children is at the forefront of the development agenda. Despite the role that women play in development, progress has been slow towards investing maternal nutrition, tracking towards nutrition targets and global goals, and advancing women's empowerment. An increase in investments and commitments is urgently needed and would result in greater acceleration towards set targets and goals, such as those listed on the right-hand side of this slide. Moving into the evidence, particularly the effectiveness of MMS versus iron and folic acid supplementation. This slide briefly presents some key findings from the most recent systematic reviews looking at MMS versus IFA. The findings strengthen the case for MMS and shows the additional health benefits, particularly for the infant, as you see on the right-hand side of the slide in red. There is strong evidence that shows that MMS further reduces the risk of a baby being born too small, that reduced risk of low birth weight, small for gestational age, as well as being born too early, and potentially reduces the risk of stillbirth and neonatal mortality. The blue box states that MMS and IFA are both equally effective at reducing the risk of anemia during pregnancies. And we know micronutrient deficiencies are relatively common in women in low and middle income countries, and we expect populations with high prevalence of deficiencies would benefit more from MMS. Evidence also shows no increased harm to pregnant women and their infants from taking MMS daily throughout pregnancy. As the evidence related to health outcomes was being updated, it was recognized there were gaps in our knowledge on the cost effectiveness of MMS compared to IFA, and this slide looks at some of those findings. In 2016, NI undertook a cost-effectiveness study comparing MMS to IFA in Pakistan, India, and Bangladesh, as noted on the left-hand side of this slide. The results of the study were published in the Journal of Nutrition in 2019, and findings showed that MMS is very cost-effective compared to iron and folic acid supplementation, and in all scenarios would avert 2 to 3 times more disability-adjusted life years than IFA. Consistent findings for Bangladesh and Burkina Faso were also published, as you see in the bottom right-hand corner, by Engelstone et al. In 2019. Moving from the evidence to key micronutrient supplementation program components for scaling up. This is a busy slide and you're not required to digest the fine print here. But as mentioned earlier, NI provides comprehensive support to maternal supplementation programs across 10 countries. We have adapted the WHO CDC logic model for micronutrient interventions to reflect our learnings and provide a more detailed program pathways that shows connections moving from left to right between program activities key to producing program outputs, ideally of women adhering and consuming to supplementation, and how this can lead to desired outcomes. We know from the evidence, if we can increase adherence to micronutrient supplements, we'll be able to accelerate progress towards national goals and targets, such as reducing and averting anemia, low birth weight, and stunting. At the activity level, which is at the left-hand side column, and the focus of today, emphasis is on sharing on ensuring a strong program foundation with priority given to essential components such as budgeting and financing, policies, product and supply, delivery, and behavior change communication. By ensuring this comprehensive approach and addressing all these areas, NI has seen an increase in program outputs, particularly women adhering to adequate amounts of supplements. The focus of the next few minutes will be on two components: one, budgeting and finance, and two, policies and the state of play relevant to these areas. The following speakers will provide more experiences related to the other components. Firstly, budget and financing. Is MMS better value for money than IFA? This is a question that many countries were and are still asking, especially relevant when there are additional costs associated with transitioning from IFA to MMS. Such costs could include additional costs for supplements, although the cost of MMS is coming down rapidly, and transition costs such as updating guidelines, training materials, and building health worker capacity. And I developed the MMS cost-benefit tool to support knowledge translation of economic evidence for country decision-making. The tool is free and publicly available online to help governments determine whether MMS is better value for money than IFA in their context. We're happy to say there is now 32 countries that have this technical analysis. A custom analysis option is also available for any country to enter their data and generate the results. And you can see on the map the countries that are already available. In all 32 countries, the findings showed with high certainty that MMS is very cost-effective, has a high return on investment, and it leads to additional positive health outcomes for newborns compared to IFA. You'll also notice in the right-hand corner of this slide is the Goalkeepers Accelerator, and I committed to the accelerator to make this tool more widely available to countries to help them to make decisions. For more information, please visit our website where you can access the tool, results for countries already uploaded, as well as policy briefs for nearly all the countries. Also, in the Science and Life magazine that's been launched today, there's an article on the tool. Moving on to policies. So the state of play of policies. In 2016, WHO launched their ANC guidelines. A part of these guidelines were 14 nutrition recommendations. There was a clear recommendation for daily iron folic acid supplementation throughout pregnancy. MMS was not recommended at the time due to gaps in evidence and potential risk to newborns. However, the guidelines from 2016 do allow MMS to be implemented in populations with high prevalence of micronutrient deficiencies. However, we know with more evidence there is now no increased harm and improved birth outcomes compared to IFA from MMS. WHO is expected to update their guidance in 2020. And at the request of WHO, we use the cost of benefit tool to conduct additional analysis that have been considered in the evidence to decision framework for updating the guideline. Just quickly, this slide is a visual representation of some of the implications mentioned by Saskia as well and considerations for micronutrient supplementation during COVID. It acknowledges the underlying micronutrient deficiencies that already exist, but then with COVID-19 brings disruptions to the health system and the food supply and compromised diets in quality and quantity. The need for adaptation-enhanced partnerships is most likely going to be required in many of the countries experiencing COVID, and considerations to strengthening the supply chain, pre-positioning supplies so women have good access to 2 to 3 months worth, considerations switching to MMS to help fill the nutritional gaps and provide additional newborn health benefits, and of course government leadership is required. So in summary, the state of play. Investing in maternal nutrition accelerates progress and women's empowerment. More recent evidence shows that MMS is safe and effective with additional benefits for newborns compared to IFA. Very cost-effective compared to IFA. MMS could be implemented now And there are many pieces that are needed to reach and sustain the desired outcomes for programs. Supporting government leadership and ownership is at the centre, and nested in with that, we need attention on policy, budgeting, finance, product supply, health system delivery, behaviour change and communication. Thank you very much.
Thanks, many thanks, Jenny, indeed, for that excellent overview of efficacy and of course cost effectiveness evidence. I'd now like to give the floor to Inraini Fitria Sia. Inraini, welcome, and over to you.
Hi everyone, it's an honor to me to be here. Thank you for Devex and DSM for arranging this important webinar. My name is Inraini Fitria Sia. I'm the head of the Summit Institute of Development. SID is an Indonesian organization focused on improving health system and human development through digital approach and human capacity building to a global standard. SID conducted the first large-scale MMS trial in pregnant women, enrolling and following over 30,000 women in Indonesia. A large-scale cluster randomized double-blind trial known as the Summit. It first to report the effect of MMS on reduction in fetal loss and infant mortality, and so the importance of MMS in anemic women. It's also the first and only trial to be locally owned and community-driven. Through the Summit, the province and the district government adopted the MMS program in their area. Learning from the successful experience of conducting MMS implementation via Summit, today I would like to share lessons from the field that we learned over time. What are the key elements that must be conducted from the project planning to the implementation? This lesson may seem obvious, but without attention being placed on those, the goal of MMS implementation to obtain high impact can be achieved. During the COVID-19 pandemic, there are additional actions to ensure the goal of MMS deployment are achievable and scalable. Of course, with optimum utilization of certain tools, there is always a way to provide MMS for every woman. I would like to go to the next slide, please. So for MMS benefit, I believe we agree that it has been proven through several trials, as the Summit study first published in the Lancet. As mentioned, comparing the effect of MMS to iron and folic acid, IFA, we observe 80% reduction in infant death, 30% reduction in postnatal mortality, and 38% reduction in infant death among anemic women. Also, 35% reduction in infant death among undernourished women. This number was achievable with the context of high participation rates and compliance. During the study, we recorded a compliance of 85%. The high compliance was determined by several factors that we address as part of the implementation. The factor will be discussed in the next slide. Slide 3, please. In Indonesia, since 1970, the IFA for pregnant women has been a national program. However, based on the basic health research in 2018, the compliance is still only 38% nationally. Many factors contribute to this low compliance, including the mothers themselves, health workers and the health system, and the project planning and implementation. As the MMS we know has greater benefit compared to IFA, it should be deployed broadly. But first, we need to address the weakness of IFA implementation in order to succeed in the MMS deployment. Next slide, please. To more deeply understand the field challenge in implementing MMS program, let's have a look at a case story from the field here. Let me introduce you to Lina. So there is Lina. She's 19 years old and have her second pregnancy now. Her first child is 2 years old. Lina was given the MMS by a midwife in the clinic and was told to consume them, but she has some talk that helped her consumption of MMS. Let's see what Lina said by going through the pieces of the puzzles. So first, based on her past experience, without MMS, her first daughter is healthy, means she doesn't have, she has experience that it's fine that she didn't consume the supplement regularly. And then another challenge is about her educational level, that she did not graduate from high school, which is put in more challenge of us to provide the health promotion of the MMS. Based on the Indonesia Central Statistical Agency, the number of women in rural area who graduated from high school is only 18.72%. The next thing Lina talked about was I cannot take supplements that are not halal. This is one example of cultural belief as one of the key elements that need to be addressed in MMS program. The majority of Indonesians are Muslims and are obligated to consume only halal food and beverage products, including supplements. Moving to the next puzzle piece is supplement preference. Lina stated, I have received IFA before, but I didn't like the taste. Taste and smell of the supplements are just one of several supplement preference specifications. From the Indonesian Basic Health Research in 2018, around 20% of the pregnant women did not like the IFA, so they did not take any, nor the recommended dose of IFA. Several other researchers have found that this is caused by the iron taste and smell and other appearance of the IFA. If we were to learn from this issue of the MMS program, we can address the need to take women's preference into account in producing the MMS. This was applied in the summit study when conducted focus group with pregnant women to identify their specific preference for the supplements, which with other activity helped to raise the compliance to 85%. Besides the unfavorable taste and smell, Lina also complained that consuming the IFA caused nausea and she didn't feel any healthier, which states the key elements of side effects and indirect benefit. Side effects are one of the barriers to women taking IFA. A decision to stop taking IFA can also be taken as the lack of knowledge of supplement benefit. We need to make sure that pregnant women fully understand how to reduce side effects and the benefit of MMS and how it works so that they are willing to consume the supplement. So for this, I would like to show the slide number 5 to slide number 9. So from slide number 5 to slide number 9, it can be shown how this one case, if it's multiple to more scalable number of women, the feasibility of each case will be difficult to see, and we need the tool to have everyone can tracking how the MMS deployment is working. So this is the part of the challenge that we need to address. And for any solution we provide, we need to track the effectiveness of the solution to make sure it's addressed the issue and has impact. The tracking tool become much more important with scalable MMS deployment. So next slide, slide number 10. Let's come back to Lina. The story of Lina includes challenges that need to be addressed in order for her to consume the MMS. The solution will include promoting the importance of MMS and the benefit for her and her baby if she consumes the MMS regularly. The message needs to be simple but strong and routinely received by Lina as a reminder. Secondly, is a platform for Lina to communicate actively and receive information anytime. At SID, we assist the mothers with customized SMS reminder that we send regularly in order to provide important information about maternal health and to keep mothers motivated about the maternal supplement consumption. We also are having a chatbot for mothers as an interactive platform to enhance mothers' knowledge and understand barriers they are facing. At SID, we assist the deployment of the project with frontline digital information system known as Open Smart Register Platform, Open SRP, that we co-founded with many international partners, including WHO. Open is considered a global good as a robust open source digital information system designed specifically for the health workers. Open SRP helps to guide and ensure complete coverage and continuity of care. The health workers include data of pregnant women, including recording supplement consumption. In addition to these tools that we use to address mothers' understanding, acceptance, and motivation to consume MMS, it is important to have a high-quality product of MMS that fits with mother preference of supplements appearance and designed to minimize possible side effects. We also need to address the halal issue as a primary cultural belief. In Indonesia, there is regulation that stipulates supplements must be halal both in ingredient and the process. Next slide. Recently, we launched a survey to identify women's preference of MMS specification and assist 407 pregnant women and women of reproductive age across Indonesia. These specifications were assessed on a Likert scale and included form, color, size, packaging, price, preferred place to obtain the supplements, and halal status of the supplements. For the packaging, we observed that the women had similar preference for bottle packaging or blister packs, but 3 out of 4 women dislike the 180 count of the tablets per pack, and 67% women agree that the supplement must be halal. We also recorded the reason for preference. One interesting response for the 180 count of the tablets was the physiological burden expressed as, "Oh, I still have so many left," and it discouraged them to consume the MMS. Through this survey, we identified preference for certain supplement specification and the related reason that either support or hold them back from high compliance. There are also other specifications not listed in the slide, but the main point is that we have to take into account the supplement specification that pregnant women like to consume and what support to take it continuously. For full coverage of the survey results, please see the article and live special report on MMS. Next slide, please. In order to conduct a national program, we need to follow a health system that consists of several levels. Providing message and understanding the importance of MMS at each level is important, but it also needs to be assisted by a system to make sure the understanding and knowledge put us on the same page. The goals and the targets need to be communicated in writing, and the capability of each person involved at each level should be assessed objectively. In this case, if the success of deployments mean that mothers need to consume MMS every day, there are certain aspects that need to be agreed. First, what is the supply source? What is supply chain? Are the mothers really consuming it? And what the proof of consumption? And all of these aspects need to be planned and carried out from the top to bottom of the health system chain, and each level needs to be certain of their role. As you can see in the slide, the midwife and community health workers, we call them cadres in Indonesia, are the point of care for maternal health and are at the end of the chain. They play a huge role in MMS program, but it's also possible that degradation of information happens, so the midwife and cadres as frontline workers do not receive the same information and do not have power to access the supply. Besides those challenges, the health workers also have high workloads with many other programs, minimum support tools, lack of supervision, and low salary. Reflecting, next slide, please. Reflecting of the challenge in health workers and health system, I'd like to share several key steps for success of MMS program from health workers and system perspective. First, working closely with the government in order to achieve goals is not just about we need to have assignment, but also written documents on the technical points that we agree to achieve. The technical points that we will work together, and we will have specific points of conduct that will assist the project and provide close communication. The agreement could also state about the changing plan or personnel from the government if the target cannot be achieved. It's always good to work closely with the central government, but in order to succeed, the involvement of the local government, in this case, the district government, can make a huge difference as they will have direct access to monitor and support the project. In the end, the successful deployment of the project will be depend on the human resource. The more active and motivated health workers are, the more knowledgeable and innovative the health workers will be lead to the success of the work. Conducting assessment to select and learn from the best health workers is one of the important key. Selection of the top health workers then need to be assisted by training, certification, tracking, and monitoring of the quality of the work. We need to ensure the capability of the health workers on doing promotion, assist the mother, providing high quality of antenatal care, reaching out to the mother if they are not coming for ANC, and monitor and motivated mothers to consume MMS. Keeping the work in the high quality zone is a challenge. So providing coaching to health workers is important so they will have renewed energy and motivation to keep doing good work. Providing incentive to the workers is also important. Next slide, please. I think I need to jump slide 15, the challenge during COVID-19. So during the COVID-19 pandemic, we all understand that we face the situation which put pregnant women in even more vulnerability, economic breakdown, and less access to high-quality food options, and hence the importance of MMS. Besides, with the social distancing, access to the antenatal care is also challenging. Of course, we need to bring the MMS idea alive, but also with providing the tools and assistance in the situation. As I mentioned before, the digital tools such OpenSRP, SMS reminder, chatbots can help the tracking MMS consumption, provide knowledge and promotion for mothers, and interactive assistance of providing COVID-19 and MMS. This time, more than ever before, we need to come and work together to close the gaps on the maternal nutrition with providing a solution such as MMS, with a comprehensive approach to save the mothers and children and keep thriving, winning the war with COVID-19. Thank you.
Many thanks, Inraini. Some great lessons from the field there, and a nice overview of the implementation challenges from two different perspectives, that of a mother and a healthcare worker. Thanks very much. I'd now like to pass the baton to Dr. Kristen M. Hurley. Kristen, welcome, and the floor is yours.
Thank you, Richard. First of all, I just wanted to quickly apologize as the formatting and colors of some of my slides have been distorted when they were transferred into the current platform, but I think most of the content is still there. So it's very nice to be here. As Richard said, I'm the Senior Vice President for Nutrition for Vitamin Angels. Vitamin Angels is a global public health nutrition organization that aims to reduce health and economic disparities across the lifespan by effectively and efficiently delivering evidence-based nutrition interventions to hard-to-reach populations. And in an effort to support the implementation of these interventions, Vitamin Angels engages in 3 key competencies, and we apply these across multiple levels and multiple partners. So for example, we work with NGOs and we work with governments. We work at either the national or the subnational level. It all depends on the context and the need. So in terms of our competencies, first, we engage in advocacy and advisory services to really help to create an enabling environment for the introduction and implementation of evidence-based nutrition interventions. Second, we provide technical assistance to ensure effective delivery through the provision of implementation research support, learning solutions, and training resources. We support the provision of high-quality product, whether it come from a donated or procured source, and we do monitoring and evaluation. And third, Vitamin Angels supports the delivery of evidence-based nutrition interventions to hard-to-reach women and children. To date, our key interventions include vitamin A supplementation and deworming for children under the age of 5, also includes the promotion of optimal infant and young child feeding practices among women with infants and young children, and we provide multiple micronutrient supplements for pregnant women. Vitamin Angels model really aims to fill gaps in coverage by delivering services to the most nutritionally vulnerable and hard-to-reach populations. For MMS, that includes women who do not receive prenatal supplements through the existing antenatal care system. But at the same time, Vitamin Angels supports efforts to expand and strengthen antenatal care systems globally by working with governments to effectively integrate MMS. So, for example, we are working with some national governments on a roadmap to introduce and scale MMS in their country or in their countries. And this roadmap is basically divided into 3 phases. Phase 1 is the preparatory and advisory phase, which is used to foster an enabling environment for MMS introduction. Phase 2 is the introduction phase, which focuses on implementation research and advancing procurement relationships around MMS. And these activities really support both supply and demand generation. And then in phase 3, it is the scaling of MMS, which focuses on expanding MMS coverage and use. So using the model and the roadmap that I just described, Vitamin Angels has made progress towards the introduction of MMS programs across various settings. And today I'm going to present 3 case studies, which includes Haiti, Dominican Republic, and Indonesia. And so, for example, the Haitian Ministry of Public Health and Population, Vitamin Angels, the Johns Hopkins Bloomberg School of Public Health, and the Haitian Health Foundation, which is an NGO in Haiti, are conducting implementation research to inform the introduction and scale up of MMS among pregnant women. And that implementation research aims to first field test the provision of MMS, including the distribution platform, the supply chain, and the cost. It also aims to develop and field test social and behavior change communication strategies and tools intended to support the uptake and adherence of MMS among pregnant women. And finally, it aims to identify and implement a methodology to evaluate MMS acceptance, coverage, and adherence. So to do this, we're working through a very systematic process as outlined here in blue on the right. And this process was informed by the Sight and Life BCC web-based training. And so for more detail on this process or our activities in Haiti, please see our publication in the Sight and Life MMS special report that just came out. The second case study is work in Dominican Republic. So back in December of 2018, the Ministry of Public Health in the Dominican Republic indicated their interest in exploring the introduction of MMS. And their existing antenatal care system reached around 96% of pregnant women. However, their IFAS supplementation program coverage was around 57%. So during a series of technical consultations with Vitamin Angels, the Ministry of Public Health noted their interest in exploring MMS as part of their newly launched national strategy for reducing infant and maternal mortality. And in 2019, Vitamin Angels provided a supply of MMS for women enrolled in the pilot program. In an attempt towards system strengthening of their existing ANC platform, the pilot program in the Dominican Republic seeks to accompany women throughout their entire pregnancy by having community health workers provide nutrition education and antenatal care support. And to help increase coverage and adherence to prenatal micronutrient supplementation, these community health workers provide pregnant women with MMS and then follow them up weekly to give support and counseling. So the Ministry of Public Health in the Dominican Republic hopes to use the findings from the pilot program to inform the scale up of a comprehensive ANC program that actually integrates MMS. And this is the last case study. This is Indonesia. So as you've heard, multiple stakeholders in Indonesia are interested in exploring the use of MMS as part of routine antenatal care services. And Vitamin Angels conducted an initial assessment to understand how best to support the introduction and scaling of MMS in Indonesia, and identified with the Ministry of Health the need to review and disseminate recent evidence on MMS to catalyze the introduction of MMS within its national health system. So we partnered with two Indonesian universities to co-sponsor a symposium at the Asian Congress of Nutrition in Bali back in August of 2019. And the purpose of that symposium was to raise awareness regarding MMS. And building on momentum from the Asian Congress of Nutrition, the Indonesian Nutrition Institute, with support from Vitamin Angels, convened a meeting in January of 2020 with participants from governments, local universities, UNICEF, NGOs, and other key stakeholders. The primary objective of this meeting was to build consensus regarding recommendations pertaining to the MMS adoption of an MMS policy. Key outputs of this meeting included consensus regarding MMS efficacy, safety, cost-effectiveness, and affordability. Another key output was the consensus regarding the need for a recommendation that leads to the formation of MMS policy. And then finally, there was the output that was that actually resulted in the development of an Indonesian MMS task force to support policy adoption. So in summary, Vitamin Angels applies its model, the one I showed at the beginning, which enables us to target and serve both hard to reach and those receiving prenatal micronutrient supplements from this regular ANC system. And in conclusion, we believe that every woman everywhere deserves a positive pregnancy experience, and that MMS makes a contribution to that, but that MMS introduction should be coupled with system strengthening to improve effective delivery. Thank you.
Many thanks for those insights, Kristen, and great to hear those case studies from Haiti, Dominican Republic, and Indonesia, 3 places very close to my heart. We'll shortly take some questions from the audience, but first I wanted to turn back to Jenny, and it's to ask this, Jenny. You outlined the scale of the issue and gave us a sense of the urgency required during your presentation, but I wanted to ask, how do we really best scale MMS efforts, and what threats or opportunities does the current COVID-19 situation present in terms of making this happen? Dr. Jennifer Bush-Hallen, over to you.
Thanks, Richard. I guess when we're looking at trying to scale and sustain micronutrient supplementation during pregnancy, if we do it looking at sort of non-COVID environment, we know from our learnings with Nutrition International, it's more than just getting a supplement and getting it to the health facility. There's a number of components going into to really program success, as I was shared in that program pathway. And over kind of 10 years of tracking and mapping this, we realized that each component that was in that program pathway, including policy, governments want clear policy and guidelines to allow this to happen. They need the budget and finance to make sure a secure supply of supplements and a health worker capacity. We've seen a huge change in kind of a success in programs when you invest in health worker capacity, particularly around interpersonal counseling and making that a positive experience for women. They are more likely to come back and adhere to supplementation. This is where the behavior change communication becomes key. And so making sure there's attention to all of those components through strengthening health systems, we've seen that ability to be able to sustain and see program success, which I think is a foundation to scaling up. In COVID, we know that there's disruptions to the health systems, to the food supply, and I think this is where we need to think creatively together in how to really ensure that women continue to get micronutrient supplementation, whether it's IFA or multis, where we think there is added benefits for the woman, and things like, can we look at inserting supplements into emergency kits, care packages, where they will have access at one time to 2 to 3 months supply instead of maybe 30 tablets per month. These are the things that I think together we need enhanced partnerships, putting government at the center of that and really working together, because we know ANC is an essential service under COVID-19, and we have to make sure women receive those some essential commodities. Thank you, Richard.
No, that's great. And perhaps just one follow-up. You'd mentioned the development of the cost-benefit tool and talking there about partnerships as well. What sort of barriers to uptake have you seen? I'm thinking particularly here about the lack of access to internet, the chronic underfunding of the health sector in many low and middle income countries for decades. What sort of initial impacts are you seeing, and where do you think it can go? What's the potential?
With the cost-benefit tool, I think with the benefit that we've seen with the cost-benefit tool, even as the supplement of MMS comes down in price and is getting close to the cost of IFA, the benefit of the tool is being able to show the additional health benefits from switching to MMS, even if the cost comes dramatically down. They see the return on investment for the long term, measured as in the dailies. We feel in COVID-19, even if there is donated supply of supplement, the tool could still be of benefit because it can show, you can adjust in the tool the lifespan. So we could look in the next 1 to 2 years, if there was a shift, say, in MMS, we could see immediately the health return that you would get on say, switching to MMS, and drawing from those health effects and the evidence. So the tool also allows us to look at over like a 10-year span, but given in this emergency situation, it could be used to influence policy decisions or decision-making during emergencies to switch to MMS to help fill that known gap of micronutrient deficiencies.
That's great. Thank you very much, Jennifer. Dr. Kristen M. Hurley, perhaps I could come to you next. You talked about scale in your presentation, walking us through the approach from advocacy to technical assistance, from M&E to implementation. I wondered what you think needs to happen to really accelerate progress on MMS efforts? And again, really, what does the current COVID-19 pandemic mean in terms of key challenges and opportunities?
Yeah, thank you, Richard. So I think there's, as I kind of walk folks through that roadmap, I just think there's a lot of, and different countries are at different places, but there's a lot of work that needs to be done around first kind of fostering an enabling environment that addresses issues of supply, ensuring that governments can either procure or import MMS or can produce it locally. There's also just the introduction of MMS and really addressing factors such as adherence. Historically, IFA, while it's been the standard of care for many years and been distributed globally, the uptake and adherence of IFA by pregnant women has been notoriously low. So there's need to do more implementation research to really figure out, are there social behavior change communication strategies that can be applied to help women change behaviors so they take it every day? Are there issues of packaging and things like that to be addressed? And then ultimately, after the issues of supply and demand and even the formation of local policy are addressed, then there's the issue of figuring out how to scale it nationally and ultimately globally. I think, and all this work is gearing up. There are a lot of stakeholders doing these types of activities. Obviously, some of the work has been slowed down a bit given the environment we're in right now with COVID-19. But I know, a lot of planning is still going forward, and with hopes in the near future that we can start rolling out these kind of different phases. and starting to work towards the kind of implementation and scale up of MMS globally. Thank you.
No, that's great. That's great, Kristen. Thanks. And perhaps we're running a little bit short on time here, and I do want to get to some audience Q&A as well. But perhaps briefly, you touched upon access there and sort of the links with system strengthening. I'm just wondering, from your experience at Vitamin Angels, how do you reach those sort of last mile populations, including those without any access to health services whatsoever?
Well, thank you, Richard. Yeah, one of VA's, what its primary aim is to fill gaps in coverage by delivering evidence-based nutrition interventions to the most nutritionally vulnerable and hard-to-reach populations, as you said. Because we know that roughly on average, and it varies by country, obviously, but we know that roughly on average, the National Health Services reach about 70% of their populations. So Vitamin Angels, we really strive to reach that remaining 30% with our different programs. So for MMS, for example, that would translate to the 30% of pregnant women who do not currently receive any prenatal supplements, including IFA, through the antenatal care system. So a good example of this work is our work in the Dominican Republic of the Congo, and it's also described in the Sight and Life MMS special report. But basically, the Ministry of Health in the DRC has actually had an existing national policy for MMS for many years. However, during an assessment launched in 2018, Vitamin Angels found that women were not receiving any prenatal supplements, so neither MMS or IFA, because of lack of resources. So VA's team of local advisors in the DRC identified the immediate opportunity to leverage its network of local NGO partners, actually, to reach an incremental number of pregnant women in the with MMS, both through local health facilities and through antenatal care community outreach programs. So we really strive to identify and target those populations through a broad network of NGO, both NGO and government partners. Thank you.
That's great, Kristen. Thanks. And Rainey, perhaps I could come to you last but not least. You outlined the issue from the perspective of mothers, healthcare workers, and gave us some insight into your MMS project. I'm just wondering, could you give us a sense of a few practical steps to ensure that women have access to MMS in Indonesia? And perhaps you could give us and our listeners a lesson on what you think could be replicated elsewhere in other country settings.
Okay, thank you, Richard, for the question. So I think one of the most important things that we have been done here to reach out the mothers, especially the one who has limited access to the health facility, is providing the MMS through the community health workers. So these community health workers is part of the MMS deployment that we train the community health workers. We provide to them with the basic health promotion about the MMS, the understanding about the MMS. Then these community health workers can reach out to the mothers on providing the MMS, not just the reach out to the mothers, but also tracking the consuming of the MMS. So they have their tools and the list that they can go from one house to another of the mothers and asking about do they consume the MMS this week, for example. And these community health workers, of course, need to be in the system of the health system itself, so it cannot be separate from the health system. And then these community health workers, we also need to think about provide incentive for them so they can, be motivated to work and providing and tracking the MMS to the mothers. So I think that's one of the things that can be done, and also, of course, have this digital health as the tools to provide the information from the community health workers and also the health workers about the number of the pregnant women at the time, how many of them that consume the MMS can be really useful, because as I mentioned before in the presentation, that more number of the pregnant women involved with this project means we have challenge to make sure all of them consume the MMS. So I think have the community health workers and also have the digital health tools to provide the information for tracking will be really helpful.
That's great, Inraini. Thank you very much. I would now like to take a few questions from the audience. We've had a lot of questions coming in, so thanks very much for those on issues such as access, scale, collaboration, and perhaps not surprisingly on COVID-19 as well. Inraini, perhaps I could stay with you. We had a question here. In your opinion, do pregnant women prefer to take MMS compared to IFA? And secondly, is MMS now part of Indonesia's routine antenatal care package?
Okay, thank you. So for the first question, I think it will be come back again of the MMS packaging, and if the woman have better understanding about the benefit of MMS. So the challenge is the understanding about the benefit is more in the level of scientists. Like, for example, of people attending this webinar, we all understand the benefit of MMS, but this information is not passed to the woman in the field, to the mothers, which make they're not really understand what the benefit of MMS. So this promotion, education to the mothers we can, especially during the COVID-19, that we cannot, directly every day meet with the pregnant woman. We can provide this information through the SMS reminder, for example. So the mothers can get information, and if they understand about the benefit and also support with the better packaging of MMS, the MMS appearance is preferred by the woman, I believe they will like the MMS more than IFA. And also for the question about antenatal care, currently for Indonesia policy, it's still using IFA for the antenatal part of the antenatal care, but in certain area, like for example in West Nusa Tenggara and some other province, they have their own policy to use MMS as a supplement for the pregnant woman.
Okay, that's great. Thanks, Inraini. Jennifer, perhaps we could come to you, and we have had a lot of questions on access. I think we touched upon that earlier, particularly last mile coverage. So I won't ask that particular thread of questions, but we do have a few questions on the WHO as well and its response. Perhaps I could come to you, Jennifer, and ask what are the chances that the WHO will update its worldwide guidance to encourage the use of MMS, and what are the advocacy efforts underway to change WHO protocols? Again, we had another one as well on how you continue to make the case that MMS would be a safe and cost-effective alternative to iron folic acid, or IFA. So again, two questions really about WHO, its guidance, and the use of MMS going forward. Jennifer, perhaps you could tackle that one first.
Thanks, Richard. That's a tough question. I'm not WHO and I can't speak on behalf of WHO, but what I do know is that this is a really important guideline for countries. Many countries, mostly, particularly the ones we work with, want that guidance from WHO. They want it to be clearer than what's in the current ANC guidelines, even though there is supportive wording to support MMS now. We know that the guideline review committee with WHO met at the end of last year. They're reviewing all the recent evidence, which is in much more favour for MMS. We expect a revision. We don't know what that will be, but we hope it's a favourable one towards making a stronger position for MMS. But nobody knows for sure what's in that guideline until it's released, but we do hope it will come very soon.
That's great, and I'm sure the WHO are keeping busy in the current environment. But yeah, we will look forward to hearing updates on those guidelines going forward. If I could move to Kristen for a last question. We had a question in that referred to the case study on the Dominican Republic that you gave earlier. Wondering about donations of MMS from Vitamin Angels. Could you describe what that looks like in a nutshell, since time is now very short indeed?
Sure, thanks, Richard. Yeah, in some cases, Vitamin Angels directly donates MMS, a product that actually contains IFA as well as the 13 other micronutrients. Vitamin Angels receives MMS as gift in kind, or we purchase MMS from manufacturers who formulate it to the UNIMAP specification. So the UNIMAP formulation or specification is the formulation that was most commonly demonstrated to improve the pregnancy and birth outcomes over and above that of IFA. But I just quickly also want to say that in addition, Vitamin Angels has been working with partners such as Humanitarian, New York Academy of Sciences, Micronutrient Forum to publish, and it has been published as part of this Site and Life Special Report, an open access product standardization document that really is intended for the use by governments and local manufacturers so that to inform either their procurement processes or their manufacturing processes. Thank you.
No, Kristen, that's great. And perhaps I can stay with you. Since time is short, I'd like to ask each of our panelists for one brief call to action. What's the one piece of advice that you have for a fellow program designer, an implementer, a donor organization official in a low and middle income country setting, perhaps someone who's seeking some guidance on how to safely and affordably provide MMS during pregnancy? Kristen, perhaps we can come to you first. A short call to action for our listeners on this webinar today.
Yeah, again, I think it goes back to my last slide. I think that pregnant women, everywhere deserve a healthy pregnancy, and MMS can support that. It can contribute to that. So, as I talked about, there's need to really work towards figuring out how to best implement MMS so it can be most effective, either whether you're targeting the hard to reach through NGOs or if you're working through the antenatal care system. Thank you.
Thanks, Kristen. Rainey, could I come to you next? A short call to action for our webinar listeners today.
Thank you, Richard. So I think from me is the key point on this is first is we need to count the woman preference on the MMS. The second one, we need to using, especially in the COVID-19 situation, we need to using the available digital tools that we can optimal use to keep providing the services to the mothers, especially in this case for MMS. So we need to, be more innovative on providing the MMS to the woman. And I think the last one is we need to keep working together in this situation, to each other, support each other on providing the good services to the mothers.
Rainey, thank you very much. Partnerships and collaboration. Jenny, could I come to you and ask you for your takeaway or your key call to action for our listeners today?
Yes, Richard, my call to action would be please invest in maternal nutrition. We need to increase commitments in terms of budget and finance, attention. And by increasing attention to maternal nutrition, MMS is something that we can help progress this attention. Micronutrient supplementation is key to really advance progress towards our committed nutrition and health targets and goals that I shared today. But not only for the health outcomes, investing in maternal nutrition really helps to advance gender equality and women's empowerment, and that is very much needed. Thank you.
Thanks very much, Jenny. Many thanks indeed to all our panelists for those really thoughtful responses, and to you, our international audience, for your questions. I'd now like to introduce Dr. Klaus Kremer, who is Managing Director at Sight and Life, to ask for his reflections on today's discussions and to give us some closing remarks and likewise a call to action as well. Klaus, welcome, and over to you. The floor is yours.
Thank you very much, Richard, for this kind introduction. I would also like to extend a big thank you to Devex and DSM for hosting this important conversation on multiple micronutrient supplements today. First, a quick introduction to Sight and Life for those who are not familiar. Sight and Life is a pioneer of nutrition innovations based on science. To catalyze science-based solutions, we work with academia, private and public sector, and funders to advance research, build partnerships, and viable social business models that have a positive impact on the nutritional status of women and children. Multiple micronutrients, or MMS, is a core priority for Sight and Life. And as our colleagues have emphasized today, MMS reduces mortality and morbidity in women and children, and much more than IFA or iron and folic acid alone. And if we do not accelerate scale up of MMS globally, life will be unnecessarily lost. In all respects, MMS is the better intervention than IFA and must be made accessible to pregnant women. The compelling evidence collected over more than 20 years of research proves that taking MMS during pregnancy is safe and has countless benefits for the mother and child. And what is notable, anemic and underweight women would benefit even more. Research has also shown that MMS can reduce the gender imbalance in terms of the survival of female neonates compared with IFA, and also represents here an opportunity to strengthen antenatal care. The cost effectiveness of MMS is proven, and the new cost-benefit tool from Nutrition International helps countries to calculate the extra benefits and costs of transitioning from IFA to MMS. And moreover, MMS has reached cost parity with IFA. However, there is a lack of information, data gaps, and clear global and national guidelines on micronutrient deficiencies, and this still prevents low and middle income countries from implementing and scaling up MMS programs. But there are several ways that the nutrition and health communities can and should come together to increase resources, provide technical support, and change the policy landscape for implementing MMS programs. First, while the World Health Organization still recommends IFA as the standard of care, we must continue to support and work with the WHO to update their guidelines on MMS in pregnancy. This is a critical step to accelerate MMS policies at the national level. Second, we must increase investments in MMS programs to catalyze a ready-to-implement solution, including production, improved supply chains, innovative delivery systems, and implementation research to create demand. This will require that the public and the private sector and even unusual partners come together. Third, documenting lessons learned and evaluating programs are key to not only guide course corrections and assess impact, but also to support the policy dialogue on MMS by demonstrating the importance and the feasibility of MMS programs. At Sight and Life, like a lot of the organizations participating today, we are working across several fronts, from research to project implementation to joint advocacy, to ensure that MMS is made available and used by the most vulnerable. For example, Site and Life has released today a new special report focusing on MMS in pregnancy that has compiled and curated the latest evidence, policy landscape, and implementation tools. All the speakers of today have made valuable contribution to this special report, and you can read more about their efforts and in greater detail in this report. We hope that the report serves as an important resource for all of you listening today, inspiring you to become advocates for driving the introduction and adoption of MMS. Providing MMS is a moral imperative and should be treated as such in all conversations. Ensuring access to MMS in low and middle income countries supports equity for women and ensures that women are empowered by putting them at the center of antenatal care. But unfortunately, in the wake of this COVID-19 pandemic, we are seeing disrupted food systems in many parts of the world, which is reducing the availability and affordability of micronutrient-rich foods such as eggs, fish, and vegetables. And this will make it even harder for women to achieve a healthy diet containing the level and variety of micronutrients needed for a positive pregnancy outcome. Therefore, investing in and accelerating of MMS programs is even more critical today than ever before and can help reduce ailments that will otherwise inevitably result from the crisis. I want to thank everyone for listening and encourage all to take part in this effort for a common standard for all women globally in antenatal care. Thank you.
I urge all listeners to download a copy of Site and Life's special report on MMS, released today, which features contributions from a number of today's speakers. It looks like we're running short on time, if not over time. So I'd like to just give a big thank you to Klaus, to Saskia, Jennifer, Inraini, and Kristen for joining us today. And thanks to you, our international audience. I think it's been a really great conversation. It's been valuable insight on maternal nutrition and MMS. And it's been a great addition to Devex's ongoing focus on improving nutrition produced in partnership with DSM. So all that remains to be said is please do have your say on today's event on social media using the hashtag #ImprovingNutrition. And we'll be in touch soon with a recording of this webinar together with a copy of the presentations. In the meantime, thanks again for your time today. Stay healthy wherever you are, and all the best from all of us at Devex.